Artificial intelligence is everywhere. You hear AI, ChatGPT, LLMs, and we're just swimming in this soup of alphabets. How do we make sense of this, particularly in light of discovery and care in the biomedical fields? We're now switching gears, and we're going to begin to talk about how AI could be and is actually used in clinical practice as well as in the education of our next clinicians. AI is simply and complexly the use of computational tools to mimic human thought, sometimes massive numbers of humans. And today we're living up to the National Academy of Medicine's goal to inspire its members and the world to think towards a future where AI becomes a trustable, understandable, theory-driven tool that supports our clinicians in practice and our patients in care. Today, we're bringing you three speakers known both for their clinical leadership and their expertise in biomedical informatics. First, we have Philip Payne from Washington University. Philip is Vice Chancellor for Biomedical Informatics and Data Science at WashU Medical School, and he is going to be providing, first and most importantly, a scoping view of AI, and with particular attention to what's happening in the clinical practice area that helps our clinicians understand how to best use these tools and help the tools better reach our clinicians. Philip comes to this perspective as a political scientist, and so he brings a systems view to the thinking. Next, we have Sarah Rossetti. Sarah is an associate professor of biomedical informatics and nursing at Columbia University. She currently co-leads the CONCERN study, which developed a machine learning model to predict patients who are getting worse in the hospital, where their concerns are showing that this person is going to need an intervention quickly. And her work with her colleagues has shown to have improvement in detection of sepsis, reduction of mortality, and most importantly, identifies points where clinicians can intervene. She also has been deeply involved in the clinician wellness, or what we might call the clinician burnout initiatives around the country. With the American Medical Informatics Association, she's been working on policies and toolkits to help manage clinician burden, particularly how AI could be of assistance. Finally, we'll hear from Chris Longhurst. Chris Longhurst is a healthcare executive from UCSD, a board-certified pediatrician and medical informaticist. His perspective is to look at the learning health system and understanding the responsibility of how institutions can build the technical infrastructure, the clinical infrastructure, and the strategies necessary to evaluate and assure the quality of AI-based interventions. I hope you'll enjoy this community of conversations, and I hope you'll bring forward messages to help us go into the future. Philip.
Great, thank you, Patty. I want to begin by saying I thought about today's panel, and I was already concerned about, as you described it, the challenge of providing a scoping review or set of comments around AI in biomedicine. That has been amplified manyfold by our keynote speaker. So I can only hope that I can follow up on that amazing talk. So I wanted to start just with this quote, because I don't think there's anything surprising about this quote, but I do think there's a set of historical frames that are very important. And first, and perhaps most importantly, AI in biomedicine is not new. As an individual who's trained in informatics, who spent my entire career working in informatics, this is the core of our field of scientific endeavor. And I think it is absolutely essential as we think about the current point in time that we find ourselves in, this inflection point around the use of AI to drive transformation in care delivery, that we are fully aware of our both responsibility and opportunity to build on decades of research and development. What has happened today is really a critical change in the practicality of bringing these types of tools into the lab, into the clinic, and into the teaching and learning environment. So just as a sort of initial point of reference, we should recognize this is not new. We have this incredible opportunity to build on what has happened before, and now is the time to take advantage of where technology has caught up with those theories and methods in order to change how we deliver care to individuals and to populations. So I wanted to begin, and I think, it is somewhat of a controversial topic to say this is the definition of AI in biomedicine. From my perspective, and what I would argue for, I think we need to focus on the role of AI in terms of its ability to enhance or augment human decision-making. Now, that does not mean that we need to think of AI as a tool that's always working alongside humans, because there is now ample evidence that there are use cases where AI can exceed human performance in the biomedical domain. But augmentation, in my mind, is about how do we make sure that humans are working on the tasks that they are uniquely skilled and capable of working on, where computers cannot replicate human cognition, and instead use that sort of augmentation to sort of draw attention to those areas and take away perhaps some of the higher friction and lower value tasks that individuals could be working on. That's AI chiming in, by the way, to the conversation. And I think, this basic premise was first put forward in a very sort of, I think, compelling way by my friend and colleague Chuck Friedman with his fundamental theorem for biomedical informatics as a field, which is not that computers are better than humans or that humans are better than computers, but rather is the combination of the two that is superior to either alone. I think it's also essential that we recognize that right now our ability, whether that be to generate new content or to interpret data as we just heard about, that ability today is much more about speed and scope than it may be about innate intelligence. That gap is closing, but we should be very thoughtful about that. And we also have to be very much aware that as we build these tools, humans are building them, and that we have to be very intentional when we address issues around, do we have the right training data? Do we understand bias, which begins with measuring it first and foremost? Do we know computational costs and environmental impact of these tools? And again, how do we take advantage of this mostly advantageous approach that's about speed as opposed to innate intelligence? Now, the National Academies have worked for some time on sort of presenting a framework which I think is very helpful when we talk about AI, which is that of learning health systems. And if we take a biological lens, we can really think about the learning health system as having this afferent process in which signals come out of the care delivery environment. And over time, as we interpret those signals, we can gain insights, deliver that new knowledge in the right time, place, and format, act, and then affect this dynamic system. And there are fundamental theories and methods from informatics, data science, computation, artificial intelligence, and many other areas that underpin that. And I think that the ability to build a learning health system, first and foremost, is can we find those patterns and act upon those patterns in, as was already introduced, the massive sea of data that we're swimming in every day. And perhaps more than anything else, AI will be the tool that makes the learning health system something that's practical and not theoretical. And I'll just end before I hand off to my colleagues by saying, as we consider the sort of human side of this equation, we really have to start being very critical in our assessment of, are we preparing a workforce and a group of leaders who are ready to develop these tools, to deploy these tools, and to use them effectively? I was very fortunate to get to work with a number of individuals, many of whom are in this room, to write this particular piece, which deals with sort of what are the needs for healthcare delivery systems to capitalize on the opportunities presented by AI. And if you sort of really drill down, there are three fundamental questions that we have to address. First is, do we have AI-ready workforce? And this is not just the people who are building AI, but do we have people working at the front lines of care delivery, operators, all of the other individuals involved in the healthcare ecosystem, including patients and communities, that are primed and ready to use these tools in effective and appropriate ways? And how do we teach that? How do we convey that message, especially in a time when trust in science is, frankly, at a bit of an all-time low? How do we move beyond the hype cycle and make sure people understand practical use cases where AI is valuable and how and where they should trust it? I think the second key question is, how do we educate clinicians to be ready to work in an AI-enabled workplace? Much like we teach clinicians today to be critical consumers of the biomedical literature, for example, reports of clinical trials, are we able to do the same in terms of helping people to understand the output of AI, which is not always definitive or binary, right? There's a hugely probabilistic nature to the output of these tools. And how do we make sure that people are ready to act on and understand that? And then last, how do we embed continuous learning into our approach to AI implementation? These are dynamic systems. The minute we deploy an AI intervention in the healthcare delivery system, we change the system, which is not just complicated, it's complex. There are many emergent features that we don't even understand today at a human biology and disease level and at an operational level in equal measure in the healthcare delivery system. And so really, as we think about the workforce needs, the leadership needs, I think we as a community have to be very critical in our assessment of, are we really building the workforce that knows how to use these tools? Do we have the leaders, and in particular the clinicians, who are critical consumers and know when and how to augment human performance using AI? And are we doing everything we can to embed continuous learning into the system such that we have an opportunity to learn and improve and don't treat this as just another technology? And I think one needs to look no farther than the history of electronic health record implementation to understand what a transformative approach looks like if we don't consider those systems level implications. So with that, and 30 seconds left,
Thank you.
I will turn things over to Sarah.
Nice work.
Thank you. So we had a vision for electronic health records that documentation, particularly for secondary purposes, would become a byproduct of patient care. This did not happen because we had to get data into the record, and our automated tools were not ready for that. So it fell to our nurses, our physicians, and other health professionals, leading to excessive documentation burden, which is a factor in clinician burnout. But picture this, it's 2030. Your health system has fully leaned into AI at all levels. You're no longer bound to the electronic health record. Instead, you're having meaningful conversations with your patients. Your day's driven by your goals of the day, your patient's goals, and the care team's shared goals. You don't feel as though you're fighting the system anymore. In fact, when there are issues with the IT systems, you're able to merely verbalize those, vocalize those, and the surrounding ambient and generative technology can capture that as you're a busy clinician at the point of care. Process that data in a way we can learn from, and our operational teams can actually have time to engage with that data for continuous learning and optimization of our systems. The way I look at our electronic health records today is as a flipped iceberg. Clinicians are faced with a lot of noise when they log in. There is a great deal of information overload, and a large amount of our data is still actually manually captured. And when you actually look at some of these data, they look the same across all of our patients. And so there's a lack of variability for us to actually use in deriving statistical signals. But beneath the surface, there is a great opportunity for signals in the data when we start to look at things such as clinician behaviors and actions, and we can start to model and amplify human expertise with that perspective. So first, let's talk about automating and removing inefficiencies. In early pilots across our country, it's looking as though ambient AI technologies, including passive inputs from audios and sensors to automate tasks, is a potential game changer. The early data is showing it may reduce burnout, reduce documentation burden, increase data completeness, and enhance care relationships. In fact, one of the most striking observations I found over the past year is that more senior experienced nurses are loving this technology even more than younger nurses, which is quite exceptional for a new technology rollout. We're also hearing from physicians that it's starting to bring back the joy to medicine. But there are potential pitfalls, such as not monitoring for new inefficiencies, errors, and burdens, and over-reliance on clinician and patient vigilance, such as ignoring cognitive science principles, and the same as the past few decades, if we do the same as the past few decades, defaulting when things go wrong to labels of that's a system training issue or user blame. So we need a culture of AI safety, where we have conditions that enable clinician and patient agency to influence AI. This could include training simulations to coach on the actual actions and how to do that. But I really believe in, even more importantly, perhaps, is a clinical environment that makes vigilance and feedback easy for busy clinicians at the point of care. A new generation of AI-based feedback tools, they're fast, intuitive, effortless at the point of care, that are AI-based, and they're actually used because our operational teams have time to engage with that data for continuous learning. Once we automate those inefficiencies, we can model and amplify human expertise. In fact, we're already doing this. I co-lead the Concern Early Warning System study with Ken Ricato, where we're modeling the tacit knowledge and expert behaviors of nurses in the hospital setting to predict patient deterioration, including sepsis, mortality, unanticipated transfers to the ICU, and to intervene on those. We know that when nurses are worried about a patient, they increase their nursing surveillance. So what does this mean? They're in the room more frequently, they're taking more assessments, they're doing additional nursing interventions, and they're escalating that communication. So we can model those behaviors of nurses through the metadata in the EHR. When we've done this in our machine learning-based model, we've been able to predict patient deterioration 2 days earlier than other early warning systems that use only physiological data, such as vital signs and lab values. Because vital signs are a late indicator of deterioration. Nurses pick up on subtle cues early on. We've built this into real-time clinical decision support in the ER, displayed to the care team, to the physician, to the nurse, and other care team members. And in a multi-site randomized controlled trial of greater than 60,000 patients, we showed a reduced risk of in-hospital mortality by 35.6%, reduced risk of sepsis by 7.5%, just over half a day shorter length of stay, and more ICU transfers, but these transfers were shown to be earlier and the patients went on to have better outcomes. Our models have actually been shown to be reproducible and generalizable by an independent team looking at them in a public data set of over 200 hospitals. We're also expanding our implementations to other populations. For this, we engage in more feature engineering for additional model builds. We're doing that for inpatient pediatrics and community hospitals. And I see this as just the beginning to model nursing expertise, physician expertise, and patient and family expertise. We're looking to include the parent input for our inpatient pediatric model, because who better to help us with an early prediction than the parent for their child? And so in summary, we need clinicians with agency that's exercised to influence AI optimization. We need sophisticated AI tools that make vigilance easy during a clinician's busy clinical shift. We need to recognize that patients and clinicians are the experts of patient care processes, and to use AI to model their tacit knowledge and expert behaviors to power new discoveries. Thank you.
Well, that's a tough act to follow, and I want to share a few stories about how AI has been used and what we've learned in our health system, because I think they are generalizable. There's no question that this tool is going to help us improve quality of care, improve patient safety, reduce clinician burnout. I think the question is how we get there. To me, the most important thing AI is going to do is restore the humanism in medicine. So the story starts November 2022, when I was actually sitting at the kitchen counter playing with that new ChatGPT tool. And one of my colleagues from UC San Diego called me up and said, "Have you played with that ChatGPT tool?" And I said, "Yeah, I'm doing it right now." He says, "Chris, I'm feeding it patient questions." I said, "Where'd you get those questions?" He said, "Well, off Reddit, of course." I said, "There's patient questions on Reddit?" He says, "Yeah, doctors volunteer to answer them." And he showed me a few of the answers, and by golly, they were really impressive. They were really impressive. And so as we started ranking them and rating them, we found what you saw here. Unfortunately, when the publication came out, the clickbait headline suggested that the chatbot was not only higher quality, but more empathetic than the doctors. But that wasn't my takeaway at all. My takeaway was that it was all about time. If you give my doctor a half an hour, 45 minutes, Google, they're going to draft a 4-page response that'll be at least as empathetic as your chatbot. But the doctors don't have that time, do they? And neither do the rest of the care team. And so while this was published in April of 23, we had the results in January. And so I called up our friends in Wisconsin and I said, "Hey, I think we've got a tool here that could help us with some of this burnout, all the after-hours pajama time that the physicians are spending, answering messages that the care team's spending." And my friends in Wisconsin said, "Absolutely, we're working with our friends in Seattle already to integrate this, Dr. Peter Lee and Eric Horvitz and others." And so along with the team at Stanford, UC San Diego became the first in the country to roll this out as an AI-assisted tool for responding to patient messages. And as we co-designed this with the vendor partners, a couple things that we built in that were really important aligned with our AI governance principles. The first was keeping a human in the loop. So you can see those buttons there. There's, respond with a draft reply or start a blank reply, but there's no just send now button because we wanted to make sure that we kept that clinician in the loop. We also have a principle of transparency. And usually we think about that as transparency of the data used to generate an algorithm or transparency of which algorithm is being used. But in this case, we had a really important question come up from our Family Advisory Council who said, should we be transparent that we're using AI to respond to patient messages? I was on the wrong side of this initially, but I became convinced. We did it, and anytime a clinician hit that button, start with draft, the addendum was automatically appended there that says your doctor has reviewed and validated this AI-generated response. So what happened? Well, we measured this as part of our learning health system. It was actually an IRB-exempt quality improvement trial, our first ever randomized QI trial at UC San Diego. And again, I was wrong. It didn't save us time. In fact, before the AI draft, it took about 30 seconds. After the AI draft, it still took 30 seconds. Because now our clinicians were reading a short patient question and a 3 or 4 paragraph draft response. But as you can see from the comments there, they loved it. And in fact, compared to the clinicians who weren't using the AI draft responses, the messages that they were sending were 3 to 4 times longer, putatively of higher quality as well, although we didn't measure it in this study. So it didn't accomplish our aim, but it is helping. And in fact, the Stanford team measured burnout using the validated Wechsler study and found that it reduced burnout. You know what else we found, though? I think is really important, is how the transparency was welcomed by our patients. In fact, Teddy Rosenbluth wrote this New York Times article where she pointed out that now several thousand hospitals across the United States use this technology to respond to hundreds of thousands or millions of patient messages, and most of those patients don't know that AI is being used. And so Dr. Millen, Dr. Tyseal, and I actually drafted this call for action in New England Journal AI, suggesting that societies like National Academy should come out with strong guidelines. And I was really pleased to say that the AI call to action and code of conduct mentions this, though I think we can get more explicit. But here's where I'm going to get a little bit provocative. So Dr. Payne mentioned before that Dr. Friedman's fundamental principle suggests that it's always the human plus the computer that will outperform the human alone. But you mentioned that in some cases it is the computer that can outperform the humans in isolation. We're seeing more and more instances of this where a human out of the loop, whether it's diagnostic reasoning or mammogram screening or others, can actually outperform the human. And I would argue that if our primary goal is improvement, not perfection, as Dr. Zach Kahani wrote in this tremendous editorial last year, that we have to be measuring how to get better rather than how to be perfect. And today, we do not deliver excellent healthcare at every visit, every time. These tools will allow us to do it. And so we've actually, at UC San Diego, started a clinical trial of taking humans out of the loop and answering patient questions. Because with explicit consent, with explicit acknowledgement, understanding of our patients, we think that most patient questions can be effectively answered without the human in the loop, which would save our care team's time. We don't know, though, and so we're going to carefully evaluate and measure it. And I'm going to wrap up with this because this is a really important call for action that we also put out last year with Dr. Karandeep Singh and some other colleagues. We don't need national labs to measure our algorithm performance. We need to measure performance of these algorithms as implemented in vivo, right? In the healthcare system. And that's what being a learning healthcare system is about, is understanding how these work in the complex and complicated environment of the healthcare that we actually deliver. And so Dr. Karandeep Singh likes to describe this as the healthcare AI paradox, which is that implemented algorithms are rarely researched, and the researched algorithms are rarely implemented. And so we're trying to close that now, and I'm looking forward very much to the panel discussion. Thank you very much, Dr. Brennan.
I want to thank, first of all, the presenters for keeping on time, which is amazing to do in this day and age. We have about a little bit of time for some moderated discussion up here, but then we're going to have time for your questions. And there are 2 microphones in the room, one on either side. In about 10 minutes, we'll be starting to take your direct questions. I am excited about the future of AI. I believe healthcare will be better, but I'm also a patient. And I want to know from each of my colleagues, how do we train, first of all, our emerging clinicians, and secondly, our mature leaders, to make effective use to be ready for this strategy? I'm going to let each of you respond. Chris.
So I'm going to be a little bit provocative again. And I'm going to say that while it's important that our students and trainees are educated about these algorithms, when PowerPoint was released, we didn't have a PowerPoint strategy. We started using it. And I think what's most important is that we're focused on the outcomes and achieving better outcomes than we deliver today. And as long as the algorithms can help us to do that and we integrate them into workflow, they're going to be widely adopted as we learn from your algorithms. And so I think it's important that we do educate the trainees, but I think it's less important that they become AI experts than they become humanistic clinicians who make eye contact at their patient encounters.
All right. Sarah.
Yeah, I've been thinking about this problem of training novices, and with the AI tools that, appear to be on the horizon, I think that we do finally have an opportunity for some tailoring in our systems that we have not always had. We will always have novices.
Yep.
And novices actually are experts at being novices. And so we have to do a better job of learning what it is they really need at the point of care. Certainly, critical appraisal of AI tools needs to be part of, core training. But what does that really mean? And how does a novice appraise the AI versus not having their expert clinical judgment attuned yet? And I think that there are differences here, and we need to acknowledge that, with perhaps the ability to tailor tools for experts, tailor tools for novices in a way that we were not able to before. We always just had to meet in the middle, and it never quite fit either end. I'll add one other observation that talking with nurses who have used the Concern early warning system, many have brought up to say this would be great to show to new nurses, to train on this practice of nursing surveillance, which really is a core part of nursing practice in the hospital setting. And so to actually use that in the output of the tool to show how nurses engage in that in real time.
Yeah, so I agree with both my colleagues. I think for starters, and I really love the metaphor that we did not have a PowerPoint strategy, and I think that is at the core what we're dealing with. What we see at WashU and at BJC, which is our partner health system, is that the people who are most successful in improving quality, safety, or outcomes or care are people that transform their clinical workflow. So it's not a tool that is sort of existing in isolation, but it is a tool that is opening up the door to changing the way we work, whether that be how we respond to patient messages or how we identify deterioration or how we manage the health of populations at scale. So I think what we're missing right now is that we need to train people to think about sort of systems level problems. How do you bring human factors, change management, really an understanding of human cognition and how technology mediates that, and how do you put those together? Because if we can empower our clinicians and our leaders alike to think in that way, rather than, frankly, the prevailing, sort of historical wisdom of this is how we've always done things, then we have an opportunity to change outcomes. And I think that goes to the second point that, both my colleagues made. If we're not measuring outcomes and the impact on patients, then we are doing this wrong. Counting the number of encounters or the number of additional visits we've added or the number of minutes saved in, work after hours or pajama time, as we like to refer to it, those are surrogates, and they don't really tell us, are we changing outcomes for our patients and communities? And again, teaching people to think in that way will lead to the types of changes that I think we want. And the last thing I'll say is, this issue around, automation of tasks fully using AI versus those that require sort of human AI partnership and sort of the stops in between, that's a great example of having to think at a systems level, right? Humans plus computers working together in the system are very powerful, but there are atomic tasks where humans could cede that responsibility to computers because they do perform better. And so that is, the type of thought process that we really need to start training people to have. And I fear that in an environment that's very resource constrained, that's very time constrained, and where there's strong historical and cultural norms, a lot of this comes down to sort of the basics of change management. So it's not a technology problem, it's a people problem.
I would like to ask one of you to speak to what can an organization, a health system or a hospital or a clinic do to create the right environment? And I think I see Chris ready to go, so.
So I had the good fortune of serving as chief medical officer for a number of years, and one of the things I helped to lead that I'm most proud of was our Acquire Committee, which is my favorite acronym. It stands for Aligning and Coordinating QI Research and Evaluation. And what it's done is it's put our IRB leaders and our hospital quality leaders at the same table to really ask the question of when is this IRB approved clinical research and when is this local quality improvement? And as a result, we've developed a database of 450 active QI projects that not only have support and resources from our health system, but also have awareness for trainees and others who want to participate in that. And so, as I mentioned, some of our AI projects require consent and they're IRB-approved research. Some of them are local quality improvement efforts to improve the outcomes of the care that we deliver, and they're part of that Acquire database. That's allowed us to much more rapidly iterate and move forward as a learning health system.
I'm going to close by asking each of the panelists to describe what is the very best AI tool you could envision in the next 5 years. And I'll tell you the one that I want. I want the one that's going to shorten the wait time in the waiting room, whatever that is.
Well, I'll be happy to start. I do like your idea of shortening the time in the waiting room, although I think most of our patients would just ask for better parking. So maybe
that's true too.
The solution. But I would say that right now, we spend a lot of time with patients navigating the care delivery system and having many what I would describe as low-value encounters before they arrive at the time and place with the right provider to get the care that they need. And I think that creates throughput problems, it creates dissatisfaction for our patients and their families, and for our clinicians, who I believe fundamentally are motivated to get the right care in place for our patients and to help them improve their health. So getting to a point where we can use AI to reduce or eliminate those low-value encounters, use our ability to predict trajectories, to really think very critically around what is the right care at the right time and place, and do that first, I think that would be transformative.
I'd like that. Sarah?
Yeah, I think we have to reflect on what we expect of our clinicians.
Yep.
You know, as we talk about system optimization, we still expect them to come to us, or even we go to them in focus groups or meetings and ask what they need. But we could use AI tools to, at the point of care, capture these pain points from them, to systematically look at what's happening. And maybe we'll find that the oncologist is struggling with the same thing that the MICU nurse is struggling with. And we would never have seen it otherwise, unless we can use this pattern recognition, continuous learning, to scale the solutions and our potential solutions. And I think this starts bringing in operational folks from our hospitals who hopefully will have freed up time from tasks that are now automated to really engage in that process.
Great. Chris?
I think the best AI tools are totally invisible, that they're frictionless, that we don't have to go ask them to be helpful to us, that they're just proactively helping us. And I think the most important thing that we could tackle harkens back to the IOM 1999 report, which is the incredible burden of preventable medical harm that continues to occur every single day in our health system. We should be building digital safety nets that use AI, that use machine vision to remove and eliminate that preventable harm that occurs every day.
I really appreciate that everyone focused on the quality of care, the quality of clinical experience, and the quality and the appropriateness of the delivery of care. So thank you so much. We're now ready for questions from the audience. There are 2 microphones ready. I'd like, if you want to speak with someone, please mention them by name. And we have about 18 minutes for this, so make your questions focused and make your answers focused. To the right here.
Thank you. This is an incredibly informative panel. I'm Jessica Kastner from Duke University and Kastner Incorporated. The opioid crisis showed us our vulnerability in research and evidence-based practice to being manipulated. AI inherently does not have moral development or a conscience, and yet this is so exciting. Talk to me about those safeguards from being manipulated once again, as we have been recently before.
So while the committee is thinking, I want to remind you, we have a full day of discussion, and we will be going into a deeper dive on ethics later this afternoon, but there may be a comment from here.
I mean, I'm happy to make an initial comment. I think, it's important to recognize that AI is not artificial in that humans are involved in developing AI. So there is an opportunity for us to at least put guardrails around these technologies. I don't think we are at a point where we understand how we would embed in a very sort of scalable way a moral code or an ethical code into AI, although there are some efforts in sort of the large language model domains to try to do that. I think that is an open question, but I would start by saying, like, teaching our providers and patients alike to be critical consumers of the output of AI is our best tool today to guard against some of the concerns that you raised.
Thank you.
I'm Anvesha Day from Genentech, and I'm part of the NAM Emerging Leaders Program. First, thank you for an incredibly helpful and enlightening panel discussion. My question is related to accountability and explainability as we are thinking of these adoption of AI more broadly in a scalable fashion in patient care. And when AI-enabled decisions lead to an adverse effect, what are the guardrails and things to keep in place here as you think of accountability?
So I'll start with, I think that we certainly need to teach this critical appraisal of our AI systems, but we also need to empower our clinicians with tools in order to be providing this feedback, because typically we know when an event occurs, there were near misses for that event leading up to it. And we have to make sure that we're looking at those and that we're capturing that information, that we're empowering our clinicians with the ability to speak up about that, but we have to make it easy for them. Filling out a large report on a safety near miss is not something that we've been that successful in getting busy clinicians to do. We don't want to leave it to the event occurring.
Yes, ma'am.
Hi, I'm Nancy Connolly, a former Robert Wood Johnson Health Policy Fellow, and an internist, and have primarily spent my time in primary care. And these tools are amazing, and I think it's amazing. That at the same time, I don't want to be having an AI doctor or an AI friend. And I'm worried that we're going to ask doctors, because they have these great tools, to do more. And relationship is so critical, and we need doctors to have time to build relationships. So I want to say I know how to fix that wait time problem, and it's to basically have fewer patients on the schedule.
I agree.
And so I want to know what you think about working in parallel to improve the systems that support the relationship between the provider and the doctor, as well as providing the whole team with the tools to do better. Thank you.
Thanks for the excellent question, and I couldn't agree with you more. Less patients will be less wait times. I think that, as I tried to express in my comments, that the most powerful potential outcome of adopting these tools is restoring the joy of practicing medicine for our clinicians and the humanism in medicine for our patients. And so we have to be very conscious and intentional about how we implement this, not as a barrier, but as a facilitator for the care that we provide. And as I mentioned, I think it's just as important that we're teaching our trainees compassion, empathy, and eye contact as it is, adopting these AI tools, because that's how we're going to bring medicine back to where it should be.
Yes, sir.
I'm Al Mully. I'm from Dartmouth. There's been discussion about AI as assistant, helping make the decision, or as a decider. And there's also been comments about full waiting rooms. I want to suggest that a focus on, among the outcomes that you're referring to, a focus on decision quality could be very helpful. Decision quality is measurable. It is measurable. And a number of investigators have been studying the measurement of decision quality for decades. And it basically makes the point that it's a service industry. And in a service industry, the product isn't something coming off an assembly line where variation is the enemy. In a service industry, it's all about the bidirectional exchange of information between somebody who knows what's possible and somebody who knows what matters to them. And decision quality is measured by making sure that the patient understands the trade-offs among the options that are possible to provide perhaps some benefit. And the clinician needs to provide that information, but also has to have the listening capacity to learn what matters to the patient in the context of their life at that moment. So I think there's an enormous opportunity for AI to improve decision quality by expanding the listening capacity, by doing its listening, and expanding the relational time that the clinician has to listen, especially to the story about, tell me what you're going through.
So maybe not so much an answer, but just to amplify your point, because I fully agree with you. We have a study underway right now, and hopefully we'll have a paper out soon, where we've been looking at the use of ambient AI in some of our ambulatory clinics that serve our highest risk patient populations, including people who are unhoused. And one of the things that we are seeing is that through the use of ambient, at least in terms of documentation from the visit and the decision-making that follows, our providers are spending more time, because they're not thinking about putting fingers to keyboards to sort of write a note. They're spending more time asking questions about the patient's, for example, housing status, or their ability to access their medications, or do they have transportation problems that prevent them from getting to their follow-up appointments. And I think that's sort of emblematic of the opportunity to enable our clinicians to make decisions together with the patients around how to form their care in a way that's responsive to their entire experience, because to Chris's point, we are sort of adding that humanism back into the engagement. So that's a place where AI is sort of taking some of the friction out of the environment to enable higher quality dialogue and decision making. Just a sort of small world example.
Very quickly, at the system level, since that's what you've been focusing on, we have found it really helpful to ask the question, how do we avoid the financial waste to the system and to those who pay for care, the harm to patients and people who care for them, and the moral injury to professionals that are such a big part of the burnout when we routinely substitute medical interventions for needed emotional and social support.
Very much for the comments. I think they're very provocative, which would fit with Chris. I want to turn for just a moment. We have people listening online. Do we have any comments or questions from people online?
Great. We do have an audience question line. So somebody from Nurse Assist AI, who is an ambient audiovisual and spatial data AI to help assaultive individuals who harm themselves or others. The panel mentioned consent, but explicit consent with vulnerable populations remains a concern. Are there any thoughts on that?
Can you restate the question? Is about, do patients understand what's happening?
So specifically for more vulnerable patient populations, informed consent.
And I think both Philip and Chris could comment, because they both deal with a wide range of populations. Can one of you speak to that? How do patients understand what's going on?
Sure. We were addressing this from a tangential standpoint on the disclosure of using AI. And I think it's a really evolving target, because we're seeing more and more AI used in scheduling and administrative functions. So how do you bring patients into that process and make them aware? It's very easy when it's explicit in front of you. The doctor asks, hey, is it okay if I record this conversation to help my note? It's much more difficult when it's a system level process, at the infrastructure level.
So we have about 8 minutes left, and we're don't want to keep you from lunch. So we're going to go with the questions of people who are in line for questions now. So if I can move over to this microphone.
Thank you. Linda Clever from Stanford. I wonder what percentage of healthcare is rendered in a system. I'm thinking of the people who aren't part of the system, whether it's the healthcare professionals or the patients. And I'm thinking of the distant areas of Alaska, for example, which has been wiped out by a typhoon, and most people don't even know that happened. And I wonder how this is all going to roll out so that there's a fairness element, and the rich don't just get richer and the poor don't get just poorer. And so how the tentacles of AI, and I think tentacles are a good thing. I mean, ask any octopus. How they are going to reach the people who perhaps need it more than anybody else.
So,
Philip, can you speak to that?
Yeah, so I love this question. You don't have to go to Alaska to find rural healthcare challenges. In my own state of Missouri, this is a huge challenge for us in terms of extending high quality care to the entirety of the population, the vast majority of which live in rural areas where they may only have critical access hospitals. And so one of the things that we've been doing in our sort of broader ecosystem for the state is building a collaborative of our large integrated delivery systems, where we are bringing in our rural healthcare delivery partners, and we are now sharing all of our experiential learning with the various sort of AI platforms that we've been deploying in our large delivery systems. We've also brought in a number of both philanthropic funders as well as sort of groups that are sort of focused more on building community health fabrics. And the goal is basically to extend that AI fabric from the large delivery systems to the smaller and community-based systems. Now you might think, why in the business model of healthcare would you do this, right? Normally you'd say, we should just build an amazing system and operate like the America Online of the internet. Everybody comes in and they never need to leave. But the reality is, from a capacity standpoint, from a quality and safety standpoint, from a patient throughput standpoint, we need this additional capability to ensure people get the care they need close to home. So we're building that capability right now, and I think it really involves health systems thinking at that system level and sharing that knowledge, that expertise with their rural partners. We're now getting into sort of partnerships with some of the most at-risk populations in our state, where we're providing virtual care, we're providing hospital home services. We are actually providing these capabilities at almost no cost to them, because it allows us to extend that care delivery environment.
Thank you. Over here, please.
A wonderful panel and fabulous keynote address. Thank you. Flora Winston from the Children's Hospital, Philadelphia, and University of Pennsylvania. I want to take a lesson that we're learning from flying and from driving, that there's a person in the loop who is, in this case, the clinician. And how are we monitoring how they're doing in the whole care of the patient? And so we are getting to determining better, what is their limit for the number of patients they can see? Where are they limited in their abilities? We see a lot with autonomous vehicles that people now trust the autonomous car, and so somebody who has disabilities is given an autonomous car, but they still are required to take over control, regardless of their inattention, their inabilities, and the reasons why they might have gotten that autonomous car to begin with. So how are we going to learn from that and bring it to medicine?
I think it's a fantastic question, and appreciate you raising it. I think, as you point out, there's a lot we can learn from automotive and airline industries and others, where they introduced automation that risked de-skilling the experts. And we know there was just a study published recently about de-skilling among gastroenterologists in Europe who are using AI-assisted colonoscopy. What's the mitigation strategy for that? It's simulation training. So pilots are brought in on an annual basis for simulation training to ensure that their skills will allow them to land the plane on the Potomac River if needed. And we're going to have to start thinking about how we move from simulation training being a nice to have to a must have for our clinicians, in my opinion.
Thank you.
But also the, just
sorry,
very quickly.
I'm going to have to move us on because we're a little tight. But Chris will be here later. Yes, ma'am.
Hi, thanks. Donna Washington from UCLA. I really appreciate the AI tools you guys presented, because it, when I think about that inverse iceberg and all the noise of the healthcare system, it really helps us cut through it. But when I think about that inverse iceberg and all the noise and where AI tools come from, they're drawing their inputs from this imperfect sense of communication. It includes implicit bias, learning from the actions of healthcare providers. It includes differential treatment. And so I'm wondering what sort of guardrails, what sort of ways of filtering that input are built into these tools?
Great question. Thank you for asking that. Absolutely. In the development of these tools, the input, we need to acknowledge those biases. I think that the science for how to do that is evolving. In our concern early warning system, we have accounted for some of those as inputs to our model, and then we've evaluated it in the output. We actually compared our model to other early warning systems that did show the outputs had some biases along racial demographics. And in our model, we mitigated that so that that wasn't happening. But we had to intentionally look at the output to make sure it wasn't doing that. And that was well before deployment. The inputs to any AI model will have those biases. And so we need processes in place from the beginning and evaluation at the end as well.
Thank you. Yes.
Hi, Jeffrey Lieberman. I'm a psychiatrist at Columbia University, and I have two very related quick questions. AI can be enormously powerful in making more efficient and more accurate all the components of clinical medicine, whether it's assessment, whether it's monitoring, whether it's the treatment, mental health care in particular. What is the issue, or how are you thinking about liability? And then the second thing is, one of my proteges started a company where they're incorporating AI into robots to provide care in a variety of different ways, virtual cyborgs. Is this something that you see as in the offing and would comment on?
Take the liability question.
Oh, absolutely. I was hoping you would.
I'm thrilled that you are, Chris. Yeah.
We're happy to have you do that.
So I saw Glenn Cohen was inducted recently in the NAM, and he wrote a terrific article in 2019 about liability around AI, where he points out that, as you say, it's evolving, because as these tools are shown to improve outcomes, it's going to go from being a liability using them to being the standard of care and a liability if you don't use them. And so this is really a moving target, and case law is just starting to evolve here. The second thing I would point out is that there's a group in Philadelphia that is writing about an approach to regulating AI that would be modeled less on our current medical software, FDA kind of processes, and more on how we license practitioners. And if you consider that licensing model, that includes maintenance of certification, continuing education, and continuing assessment. And I think that that model is a better model longer term for how we're looking at these evolving decision support tools.
Anybody want to touch the robot one?
I'll make an entirely non-factual statement. If you ask GPT to draw a picture of an AI-enabled healthcare system, there's always a robot in it. So I don't know what to make of that, but take it as you will.
I'm going to point out that when I asked the panel their vision of AI advances in the next 5 years, nobody said robotic nurses, and I was glad of that. Last question, please. Thank you.
I'm Mark Smith. I'm from Oakland, California. I thought I'd jack up Chris's level of provocation a bit.
Okay.
Suggestion and a question. The suggestion is that you reflect on the fact that all three of you used what I thought was kind of a quaint term, the point of care, which was kind of bizarrely anachronistic given what we're talking about. I think what you meant was a relatively narrow group of clinicians who meet on our turf with people in person with someone who's been to school for 18 years. And so I just think you might want to think about how we may still be stuck in kind of a mental image of what we mean by care if we think it has a point. My question is this: there are clearly areas where AI is better than humans, where there isn't the fig leaf of humanism and longitudinal relationship, where the clinician doesn't have a longitudinal relationship with the patient, often never meets the patient. They're looking at slides, they're looking at MRIs, they're looking at nuclear medicine, they're looking at EKGs, and our inability to get humans out of the loop is part of why healthcare costs so much, because the people who control those specialties have instituted guild rules that make our care confiscatory. So my question, in line with the notion about auto driving, what can we do to create enough professional and public confidence in AI that we can allow it to do what it does better to humans than humans, to allow the healthcare system to become more accessible and affordable?
Oh, that's great. Very good. All right.
We agree.
And
I mean, I guess I would say I actually think Chris's comment that we agree is the only answer to that. I think fundamentally a question in front of an audience like this is how do we build trust and understanding? How do we sort of take this viewpoint that we need to transform the delivery system? How do we, as you said, expand the definition of what is the point of care, which could become everywhere and should? And lastly, how do we make sure that we are taking sort of activities out of the system that could be automated so that when humans interact and we restore humanism in medicine, it's in those times and places where that human interaction adds value and improves outcomes. So the question is not how do we take the current system that we have and bolt AI onto it, it's how do we build a new healthcare delivery system that incorporates all these dimensions that we just talked about, that delivers on that promise, that actually improves care for individuals and communities. So I think that's a longer-winded way of saying yes.
Thank you.
Sarah, do you want to comment? Do you want to comment?
Well, part of that vision too is as we automate, we have to make sure we protect clinicians' time.
Yep.
So we can't be adding more tasks back to them, or else we're not going to realize the vision that Philip was articulating.
And I'm going to take the chair's perspective and say we have to look at financial incentives and the perversity of some of them that exist right now to make sure we don't bake those into the AI system.